Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 521 of our pharmacotherapy series, which majors in renal dialysis. This case refers to patient ROW discussed in part 520 of this pharmacotherapy series. I would like you to recommend a reasonable anticoagulation regimen for ROW with the initiation of his hemodialysis. What are alternatives for patients at high risk for bleeding? The correct response is, most patients undergoing hemodialysis are anticoagulated with IV heparin during the dialysis treatment. Anticoagulation is necessary to prevent blood from clotting in the extracorporeal circuit. Several methods have been used in an attempt to provide adequate anticoagulation without increasing the risk of bleeding. Approaches include the administration of heparin in adequate quantities to anticoagulate the patient during the dialysis procedure by either intermittent bolus injections or an initial bolus followed by a continuous infusion. Modern hemodialysis delivery systems have incorporated heparin infusion devices that can be programmed to provide the desired infusion rate during dialysis. With no evidence of a bleeding disorder, recent surgery, or other risk factors for heparin anticoagulation, therapy should be initiated with a 2,000 unit bolus of IV heparin 3 to 5 minutes before initiation of dialysis, followed by an infusion of 1,200 units per hour. The target activated clotting time, abbreviated as ACT, is 40% to 80% above the average baseline for the dialysis unit, e.g., 200 to 250 seconds, for normal values of 120 to 150 seconds. The clinician should monitor for signs of bleeding and measure the activated clotting time at 1-hour intervals during dialysis. Heparin should be discontinued 1 hour before the end of dialysis to prevent excessive bleeding after dialysis. Using these standard doses, the estimated elimination half-life for heparin is approximately 50 minutes, and it should have a linear dose-response relationship within the target activated clotting time. Patients at increased risk of bleeding include those who have had recent surgery, retinopathy, gastrointestinal bleeding, and cerebrovascular bleeding. For these patients, the goal is to prevent clot formation within the dialysis circuit as well as to minimize the risk of active bleeding. This may be accomplished by using minimal dose heparin, tight activated clotting time control, or even heparin-free anticoagulation. The minimal dose heparin approach individualizes therapy to achieve activated clotting time values 40% above baseline after an initial bolus of 750 units. The activated clotting time is measured 3 minutes after the bolus dose, which should allow for vascular distribution of the heparin to be complete. If the goal activated clotting time level is not achieved, repeat bolus doses of heparin can be administered at a dose that is adjusted based on the expectation of a linear response. For example, if the first dose of 750 units reaches 75% of the activated clotting time goal, an additional 250 units would be appropriate for the second dose. Similarly, the initial heparin maintenance infusion rate of 600 units per hour can be modified by monitoring the activated clotting time at 30-minute intervals. Adjustments in the infusion rate should be proportionate to the bolus dose needed to maintain the activated clotting time at 40% above baseline. Samples collected for determination of activated clotting time should be obtained from the arterial line into the dialyzer before the infusion of heparin to reflect systemic anticoagulation effects. Heparin-free dialysis is an alternative to heparinization for hemodialysis patients who are at a moderate to high risk of bleeding or who are actively bleeding. This approach requires priming the hemodialysis circuit and dialyzer with heparin 3000 units per liter in normal saline to coat the extracorporeal surfaces. The heparin-containing priming fluid is allowed to drain by filling the circuit with either the patient's blood or normal saline alone at the outset of dialysis. Next, hemodialysis is set at a high blood flow rate of 300 to 400 milliliters per minute, if tolerated. During dialysis, the dialyzer is flushed with normal saline every 15 to 30 minutes to rinse away microclots that may have formed. The incidence of clotting with this approach is approximately 5%. The regional administration of trisodium citrate through the arterial line is an alternative to systemic anticoagulation. It binds free calcium, which is necessary for the coagulation process. The calcium citrate complex is removed by the dialysate and, based on plasma calcium values, calcium chloride is administered on the venous side to replace the citrate-bound calcium to prevent hypercalcemia or hypercalcemia. Some of the administered citrate is returned to the patient and is metabolized to bicarbonate, leading to metabolic alkalosis in some cases. Trisodium citrate may lead to hyponatremia. Regional citrate anticoagulation is reserved for patients who are at risk for bleeding and requires additional monitoring to adjust the dual infusions. In a prospective study of 1,009 consecutive high-flux dialysis procedures in 59 patients, long-term citrate anticoagulation achieved excellent anticoagulation, that is 99.6%, with rare, that is 0.2%, adverse effects on ionized calcium levels, electrolytes, and acid-base balance. The next question reads, can low molecular weight heparins, abbreviated as LMWH, be used for hemodialysis? Enoxaparin, dalteparin, and tinzaparin are low molecular weight heparins that are commercially available, but not yet approved by the U.S. Food and Drug Administration for hemodialysis. In a meta-analysis of 11 randomized trials, low molecular weight heparin was compared with unfractionated heparin in end-stage renal disease patients undergoing either hemodialysis or hemofiltration. Low molecular weight heparins did not significantly affect the number of bleeding events, relative risk of 0.96, with a 95% confidence interval of 0.27 to 3.43, or extracorporeal circuit thrombosis, relative risk of 1.15, with a 95% confidence interval of 0. 7 to 1.91, compared with unfractionated heparin. In a randomized, crossover study comparing the safety and efficacy of enoxaparin with standard heparin, a dose of 1 mg per kilogram body weight of enoxaparin produced less minor fibrin or clot formation in the dialyzer but more frequent minor hemorrhage between dialyses. Dosage reduction of enoxaparin to 0.7 mg per kilogram body weight resulted in similar efficacy and eliminated the minor hemorrhage. Dalteparin administered as a single bolus dose of 60 high flux was effective in preventing clotting of the hemodialysis circuit with no reports of bleeding. Tinzaparin has also been shown to be effective as an anticoagulant during hemodialysis, using a weight-based IV dose of 75 international units per kilogram or a fixed IV dose of 2,500 international units just before dialysis. Although low molecular weight heparins can be used to prevent clotting during hemodialysis, several factors need to be taken into account when considering low molecular weight heparins for prevention and treatment of venous thromboembolism in hemodialysis patients. Because low molecular weight heparins undergoes renal elimination, dose adjustments are necessary in patients with end-stage renal disease, accompanied by careful patient monitoring. Although low molecular weight heparins inhibits factor Xa, factor 12A, and kallikrein, measurement of anti-factor Xa activity is the only available laboratory monitoring parameter for these factors, because active heparin metabolites that are not detected by the factor Xa assay can accumulate in dialysis patients. The clinical utility of this test is unclear. Another concern with low molecular weight heparins is that patients on dialysis exhibit greater sensitivity to its effect than healthy volunteers. Furthermore, low molecular weight heparins administered at fixed weight doses and without monitoring shows unpredictable anticoagulant effects in patients with stage 4 and 5 chronic kidney disease. In a case series of patients on hemodialysis treated with low molecular weight heparins for acute coronary syndrome, 2 patients who received as few as 2 to 3 doses of low molecular weight heparins exhibited dialysis access site bleeding, hematuria, and massive melena. Another subject who received 10 doses experienced hemorrhagic pericardial effusion, resulting in death. Only 1 patient in the series, who received a total of 5 doses, did not have hemorrhagic complications. Based on these findings, it is recommended that unfractionated heparin, rather than low molecular weight heparins, be used in patients on dialysis for prophylaxis and treatment of thromboembolic disease. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 522.